You can't see all of our smiling faces behind these masks, but we're very happy that we're coming to the end of a long week and looking forward to spending time. Those of us that are fathers, we're looking forward to Father's Day this weekend. For those of you on the phone, hopefully you'll have a wonderful Father's Day weekend as well. Most of you, we've got a great turnout today for the Circle of Excellence presentation. I'm Mike Marsh. I have the privilege of serving as Overlake CEO. Most of you know me well. There are a few of you that I've not had the privilege to meet. But before I talk a little bit about today's topic and introduce our presenters, I did want to make sure I took time out to thank each of you, and not only for participating and showing your interest in today's discussion, but also in your many contributions to Overlake. The names on the individuals who are on this call are really an impressive group of community leaders and friends of Overlake that have made this organization great for many, many years, and thank you very much for all that you do. Today's topic is to provide you an update on our Cancer Center. It's hard to believe that it's been 3 years since our grand opening. I think 3 years in July, was it? Did we open in July? Yeah. And also to provide you with an overview of our new partnership with the Seattle Cancer Care Alliance. You know, I am so proud of Overlake's Cancer Center. We are a great example of a clinical service that recognizes that you need to have both compassionate care with a sense of person-to-person relationships at the same time that it's surrounded by the best technology and the most competent providers available to the state of the science. So we have that surrounded by a team-based approach of providers who recognize that they need to come to the patient in coordination around these complex cases instead of the patient trying to find them. And so that integrated approach was really at the heart of this Cancer Center and will continue to be at the heart of this Cancer Center as we move into our partnership with the Cancer Care Alliance. I do want to recognize also that in addition to your general support for Overlake, there are many of you that are on this call that were instrumental to our new Cancer Center becoming a reality, both in your time and in your resources. Over 50% of the Cancer Center was built on philanthropic support. That's just a really remarkable achievement that demonstrates this community's support for this service. So with that, I'd like to introduce our presenters today. We have with us at the end of the table, they look probably like they're about 2 feet tall on your picture, Dr. Christy Harrington and our Chief Strategy Officer, John Duarte. Dr. Harrington has been a breast surgical oncologist since 2001. Her practice focused on highly individualized interdisciplinary management of breast cancer to achieve the best possible outcomes. Her goal is to see newly diagnosed patients within 48 hours to help reduce anxiety that accompanies a cancer diagnosis. She's really a treasure on our medical staff and has been a champion both of the Cancer Center and also this partnership. So she's really a terrific individual to have with us here today. John Duarte joined Overlake in 2014. He actually joined, I think, a month after I started. He's always been just a little bit behind me, so that doesn't surprise me. A week, okay. He's been instrumental. John is a brilliant strategic mind. He's been instrumental in Overlake's strategic direction on so many different fronts, including our institutional partnerships like this one with SCCA, our clinic network development, planning for Project Future Care, just to name a few. So as a person who grew up in the strategy side of healthcare, I can tell you that John is among the best that I've ever worked with in this particular area. Christy will talk about what's been going on with the Cancer Center since we opened 3 years ago, and John will talk mostly about the partnership. So before we start, I'm going to turn it to Scott Waters, who's helping to moderate this event, provide you with some basic logistics to how you can participate on this call and get your questions answered along the way. So Scott, I'm going to turn it over to you.
Thank you, Mike. Just a couple of logistics and areas where you can reach out for help or ask questions. So you should have received an email from Katie Sims today with some instructions. If you have questions for our presenters, you can enter those into the chat box, which some of you have already been doing, and I'll be looking at those and passing those on to our presenters today. And then you can also send your questions via email to katie.sims@overlakehospital.org. That should also be in that email that Katie sent out to all the participants or the attendees today. If you're having any technical difficulties, we have a phone number for you to call. You can reach out to Mike Lacey, and that's also in that invite. The phone number is 425-688-5570. And then as far as a couple of webinar etiquette topics, I've muted everybody's microphone, so you don't need to do that on your end, so I'll take care of that. And try not to share any video that you don't want people to see. So we're all looking at the same video feed. Other than that, questions, concerns, you can send via the chat.
Can you direct people to where the chat is? I mean,
yes, I can show them real quick if you want.
Just so you see, the chat is really the best way to ask questions along the way. And not all of you may be familiar with where that is.
Okay. So real quick, we'll take 5 seconds here, and I'll show you where you can find the chat. Right now, we get to see
Jan Conrad.
video feed there.
Yeah.
All right, so this is the video feed of everybody. But if you're looking for the chat function within your window, it's going to be along the bottom here. And you're going to click on this icon that has a little, it's the chat icon, and it'll pop up a chat window on the right of your screen. And you're seeing that. Okay? All right, I'll jump back into the content.
All right, are we ready to roll?
Yes.
Okay, Dr. Harrington.
Great. Good afternoon, everybody. It's my pleasure to be here. Mike, thanks for the great introduction. To speak about something near and dear to my heart, the cancer program at Overlake. It's been 3 years, I think, since, as Mike said, that sorry, I just pushed too hard with my thumb. There we go. 3 years since we officially opened our cancer center at Overlake, our newly remodeled cancer center. Again, thank you all for your wonderful community support, which raised over half of the dollar amount to open our cancer center. And more importantly, thank you so much for your input into what we needed to provide to our patients to help them through their cancer journey. Our cancer center is what it is today because of that input, and it has been so well received by our patients, and we cannot thank you enough for your support. We continue to receive support for our cancer center through endowments and designated donations from our community members, such as yourselves, and through the Tree of Hope, which you see pictured here. So we were truly built by and for the community. Those of you who were able to participate in our celebratory opening 3 years ago may remember this. It was a depiction of the cancer patient's journey. We are happy to report that this menu of services that we were committed to providing is now available to our patients in the Cancer Center. Our Cancer Center receives psychosocial support through our oncology social workers, oncology navigation, which I'll speak to later on in my talk, financial counseling, physical therapy through a dedicated oncology physical therapy suite with, for example, lymphedema certified physical therapist, an oncology dietitian to provide nutritional support, Oncology massage therapy, which is probably one of our most popular supportive services. Support groups, primarily through our affiliation with Cancer Lifeline, such an important organization which we love being able to partner with. And also with supportive and palliative care provided right in our cancer center, a kind of unique model. If we look at how many people that we've helped since our opening, it's truly a tremendous number of people. Over 32,000 people diagnosed with cancer have been treated in our center in the last 3 years. This includes over 23,000 in our breast health center. And as many of you probably know, cancer treatment doesn't happen in one visit. It requires multiple visits with providers for surgery, for chemotherapy, for radiation treatment. We've had 160,000 patient visits, over 58,000 visits every year. And we seem to be doing a good job. Patients rate our experience with us as a 9 or a 10, 90% of our patients. So thank you again for allowing us to be in the community and to provide this care. We haven't been at rest since we opened. We are focused on advancing our capabilities. Specifically, I'd like to speak about adding multiple subspecialty surgical oncologists, expanding our technologies for use in cancer treatment, and continuing to enhance our patient experience through growing our navigation and supportive services. So I'll speak individually about each of these things. In terms of surgical subspecialists, we've been happy to grow our team with these providers. Dr. Pam Paley has joined us in gynecologic oncology. She has about 25 years of experience, primarily, most recently in the Pacific Northwest, and has chosen to make Overlake her permanent home. She's an awesome provider, very personalized care, and an excellent robotic surgeon. Dr. Sung Cho has joined us with a specialty in hepatobiliary and pancreatic surgery. Doctors Preetha Ali, and in the middle on the bottom, Dr. Ian White, have joined us with subspecialty training in colorectal surgery, and again, especially trained in robotic surgery. Dr. Nick Serrano has joined us in radiation oncology, replacing one of our providers who retired. Many of you may have known Dr. Jim Pelton. He's been with Overlake for many years. Dr. Serrano has a specialty training, fellowship training in prostate radiation therapy. Dr. April Santana Ancul has joined me in the breast surgery practice, replacing Dr. Rick Klarfeld, who I'm sure many of you know, as he had been here with me at Overlake for almost 20 years. Dr. Santana Ancul is fellowship trained in breast surgery and brings with her a special expertise in oncoplastic surgical techniques. And Dr. Scott Lewis joins our cardiothoracic surgery team with specialty training in minimally invasive thoracic surgery. He spends some of his time here at Overlake and is in our partnership with Evergreen Hospital. So they really serve to expand our team and provide us with additional capabilities. They're wonderful team members, participate actively in clinical trials and in our cancer committee. So we're very excited to have them with us. And surgeons need good equipment, and our team at Overlake has been very committed to providing the surgeons with the tools that they need to advance surgical care of oncology patients. Specifically, Overlake has purchased 2 Da Vinci Xi surgical robots, and I'm told that these are like the cherry on top of the sundae. These are the latest and greatest in robotic technology.
Very expensive cherry.
Yes, I know. Well, maybe it's the orchard. Okay. So I personally don't perform robotic surgery, but I'm told that this is the top of the line. They're used in minimally invasive surgeries for many types of cancer, The thing with minimally invasive surgery, the reason why that's so important is because it decreases the patient's downtime after surgery. The incisions used to perform these very complex surgeries are 1.5 centimeters long, maybe 4 different incisions, so the healing time is much expedited. Robotic surgery techniques are used in prostate and kidney cancers by our urologic surgeons. Ovarian, endometrial, and uterine and cervical cancers are treated by our gynecologic oncologists like Dr. Paley, Drs. Preetha and Ali, and other community colorectal surgeons use the Da Vinci robot for colon and other intestinal surgeries. And they can also be used, the robotic technique can be used for lung cancer surgery. What you'll see pictured, the top photograph, is one of our community urologists who is performing a prostatic resection with the robot technique. He's sitting at a console. His hands are nowhere near the patient. The patient's sterilely draped and has surgical instruments entering their abdomen and pelvis via these very small incisions. And the surgeon is performing this very complex surgery remotely. Of course, the patient has an anesthesiologist at their head, monitoring all their vital signs and administering pain medicines and anesthetics. But it's amazing that this very complex surgical procedure can be performed in this way. And in the bottom photograph, you see the Da Vinci Xi. I should mention that our expanded surgical team joins a number of other surgical subspecialists that I haven't called out because they've been on our team for a while, but this includes neurosurgeons, other general surgeons who perform complex intra-abdominal cases. So we really have a very well-rounded team of surgical subspecialists. In terms of advances in breast surgical technology, we have recently, through the generous assistance of the donor, acquired the SavvyScout wireless localization technology. This is truly amazing. Any of you on the call who have ever had a breast surgical procedure for a non-palpable lesion maybe will recall having a wire placed into your breast to guide the surgeon to the area to be resected. That's completely gone by the wayside with this technology. What this technology allows for is a radar clip called a Scout or SavvyScout radar clip placed days or even months prior to surgery at the site of the tumor in the breast. This, of course, greatly reduces the amount of stress on the day of the procedure. You come into the hospital and you can go to sleep rather than going to various places and having local anesthetic for a procedure prior to the procedure. So it's a real patient satisfier. And then intraoperatively, you can see that probe up there at the top with the purple handle is attached to that box. And that probe is merely run over the surface of the breast or can even be sterilely draped and used inside the breast to locate that clip. And on the console, you'll get a readout of the distance away from the clip so that the surgeon can very precisely remove the tumor. This allows for incisions to be made in more remote, cosmetically appealing locations. It allows for more assuredness that the correct area has been removed. It actually, I think, reduces the operating room time because it's so precise. And it greatly enhances patient satisfaction. The other thing that it does is it allows us to do more surgical cases in one day because we don't have to have the patient have multiple procedures before they can even arrive into the operating room. So what this does is that it increases the throughput in the operating room, thereby decreasing the time from diagnosis to surgery. So again, one of the things that's most stressful for a cancer patient is typically that waiting time. So we're very pleased to be able to offer this technology. Another technology that we have acquired is the ability to do video-assisted thoracoscopic lobectomy. And basically what this means is, again, using small incisions. You can see the diagram of the patient there with the long-handled instruments entering through small incisions into the thorax, and then through one small incision being able to insert a camera and then performing the surgery in that manner to resect a small portion of the lung tissue. The traditional open lobectomy technique involved a multiple inch long incision placed between the ribs and then using a rib spreader to gain entry and visualization of the tissue. So as you can imagine, the VATS lobectomy is much less painful, has a much shorter healing time, and still allows the surgeon to do their job. So we're very excited to be able to offer these technologies. But we don't only advance cancer care through machines. We also advance cancer care through helping our patients navigate their cancer journey. We have always employed a number of oncology social workers who have done a fabulous job of assisting patients through the complex treatment network and the psychosocial challenges of a cancer diagnosis. And a lot of our oncology social work support has come through the Clodagh and Bob Ash endowment to our oncology social work department, and we can't be, we're so thankful for that. But we're actually very excited to progress into the next phase of patient navigation with the hiring of registered nurse navigators to help patients with the more clinical aspects of their care. So what we envision is that the oncology social workers will continue to focus on the psychosocial challenges of the diagnosis, which admittedly can be very daunting, but we'll have more clinical expertise with registered nurses who regularly communicate with the physicians on the cancer team and are able to provide education and information on treatment options. Will be assigned to the patient at the start of their cancer journey and will remain with the patient through the entire cancer journey. They will help on coordinating transitions of care, say for example, when chemotherapy has ended and the patient needs to now see the radiation oncologist. They will help expedite care by facilitating test ordering and getting outside information. For example, if the patient was diagnosed at another center and comes to that's going to help that visit go more smoothly, again, decreasing the time between diagnosis and treatment. And then once care is complete, the RN navigator will help coordinate the patient's survivorship visit and help them be on a regular schedule for their follow-up treatment. We know that sometimes patients can get pretty confused during their cancer treatment because it's a confusing situation. And so we think the addition of a clinical navigator to our team will greatly decrease anxiety through the care continuum. And finally, we all know that COVID-19 has changed our lives quite a bit. But cancer care doesn't stop for a pandemic. And we have cared through a number of patients during the pandemic. Our patients and visitors are all screened daily for symptoms, and they get their temperature checked with a touchless thermometer. We've had to do some changes in visitation. We want our patients to be supported through their journey, but their visitors are limited to only one person per patient. Our screening visits for screening mammogram were stopped for a time during the initial phase 1 of the pandemic because we wanted to make sure that we had all of the safety things in place before resuming the screening. So we started that again in mid-May, and we have social distancing measures in place for staggering appointments. We're not keeping people waiting. We've spread out the chairs in the waiting room. So we're doing everything we can to ensure that that you are safe in our care. We did continue to perform oncologic surgeries for cancer during the acute phases of the pandemic, if that was the first best treatment for the patient. Some surgeries were delayed because the patients had other good options. They might have needed to start chemotherapy before they had surgery. They might have been an older patient with a very good prognosis tumor who could safely be put on an oral medication for a few months until, again, the CDC and the government all said, hey, it's time to come back and do those more elective cases. All of our surgical patients now are currently undergoing coding within 48 hours of surgery. So we have the testing capability, we have the PPE available, and we want you all to know that it is safe to come in for care. And in some instances, when patients just need a conversation with their doctor or a review of symptoms that they were having, some of those visits were converted to telemedicine if that was appropriate for the patient. I know I myself did a number of telemedicine visits during phase 1 of the pandemic to provide reassurance to the patient, to talk to them and see if there was any symptoms that they did need to come in for, or whether or not we could safely delay those visits for 6 weeks or so until it was safer. So I think that worked out really well. And we're very, again, appreciative of our partnership with Cancer Lifeline. Cancer Lifeline has been routinely providing support groups and educational classes for our patients since our cancer center opened 3 years ago. And through all of the new WebEx and Zoom technology, Cancer Lifeline has converted many of the support groups to virtual support groups. And I have to tell you, having treated patients who were diagnosed with cancer during a pandemic, what a frightening situation. I had patients tell me, oh my goodness, I feel like this is the time in my life when I need the most support, right? But they were, you know, we were telling everybody to stay socially isolated at home so that they could be safe, right? And so the institution of virtual support groups has been so well received by our patients. We can't wait until we can get everybody back in for those support groups sometime in the future, but I think we've done a really good job of responding to the situation and caring for our patients. So with that, I think I'll turn it over to John.
Great, thank you, Christy.
Yeah.
So again, yeah, thank you for everybody joining us today. You know, obviously the cancer program has been doing a lot of work over the past few years in terms of advancing and developing capabilities, technologies, people to support our patients. You know, I'd like to talk a little bit about probably what you had received announcement about and seen in the news related to our partnership with Seattle Cancer Care Alliance that's slated to commence on July 1st. That's also something that has continued in terms of our work through this pandemic in terms of executing on this partnership. So this was a partnership that was probably close to 3 years in the making. The two organizations had some discussions and, you know, kind of came to the conclusion that as opposed to duplicating care on the east side for cancer, that we were really stronger together and can provide better care together than we could individually. And I think that's really the genesis of this discussion was looking at how we can be better together, which is actually the Cancer Care Alliance's motto, but I think also was something that we really felt was an opportunity for our patients and our program at Overlake. And so we really are thinking about this as one program, two organizations coming together to provide the cancer care. We both have individual strengths that we believe will be maximized through this relationship, and we'll still be striving to deliver that seamless, accessible care that Overlake is known for and maintaining the high quality and outcomes as well. So this is really to kind of illustrate some of the ideas behind the partnership and how we did feel like we were better together. You know, SCCA, as many of you all know, is nationally recognized. They're one of 10 dedicated cancer care centers in the country. They're in the category that Dana-Farber is in, that Sloan Kettering, MD Anderson, City of Hope, those types of organizations that are exclusively dedicated to caring for cancer. On our side, on the Overlake side, we are dedicated to the east side, dedicated to treating our patients and serving our community. And so this was really sort of the best of both worlds, where you have organization with sort of the academic and the research and trial backbone, an organization focused on providing the highest quality personalized care to our community, and also having the tertiary, the more advanced surgical and diagnostic capabilities locally that we felt was really what was going to be additive to the community and our patients. One of the compelling things we looked at in assessing this opportunity was our local service area, the east side preferences for cancer care. When you looked at SCCA and Overlake, they were about equal in terms of the preference, as a percentage of the population. And when we combined the two, which is kind of the essence of what we're doing here with this partnership, by far it was the preferred provider for compared to any other option on the east side, Swedish, VM, et cetera. Additionally, there was a lot of folks in that survey. This was, something that we did through National Research Corporation. A number of people had no preference because they haven't had to deal with this, with cancer in their lives. But looking at the combined strengths of a local, dedicated hospital that also had the backing of a nationally recognized research institution, was a very compelling option for folks that are considering where to get their care. So really, it was, we felt that there was a lot to be gained from both sides in terms of this partnership. The structure of the partnership is similar to what exists currently at Evergreen, in that the medical oncology and infusion aspects of Overlake's Cancer Center today would be operated by Seattle Cancer Care Alliance. Those physicians and providers currently employed under Overlake are transitioning their employment to the UWP, which is UW Physicians, that serves as the practice group for SCCA medical oncology. Everything that Overlake does today would remain the same in terms of our surgical, our radiation oncology, ancillary testing, all the services, but the partnership at the portion that SCCA would be operating is medical oncology and infusion. I want to stress that this is in the exact same place that it occurs today. And so there's still the vision and the co-location of services that we had. And I would also add that I think one of the things that was really important about the genesis of this partnership was the fact that we did have a localized cancer center that included all this. It was the vision that we had hoped to achieve in 2017 by bringing all these services together. This was really attractive to both, in terms of actualizing this partnership. And can't thank everybody enough for their support in that. And because that really was what helped to make this all possible as well. SCCA operates a closed clinical trials network that's only available to their affiliates. Through this partnership, our patients will have access to those clinical trials both locally and as needed, for more specialized trials, at their location. But this is really additive to the community. And they are, as folks know, the Fred Hutchinson Cancer Research Institute is a force in the United States for cancer research and, some of the basic science research coming out for cancer care. And that is as one of the partners in SCCA, they contribute a lot of those advanced technologies, emerging therapies that are really going to be a great option for Eastside communities here. We will always be striving to coordinate the care. We recognize that this is adding in some additional levels of complexity by having two organizations, but we are trying to maintain, as we'll talk about in some of the later slides, a lot of the things that exist today in terms of how the patients are coordinated and cared for within the Overlake Cancer Center. A few other just things is related to how we're going to work together. We're going to have a joint leader that has dual reporting relationships to both organizations to really help to bring together and execute on some of the intentions we have around partnership and what we'd like to see for the care provided here. We have a number of different joint marketing efforts that we're going to do, coordinated marketing efforts to get the word out about the program and the services provided. And, through this, we would see that both institutions would benefit from growth of the cancer program here. Unfortunately, due to the aging of the population, we will only be seeing incidents of cancer rise. And so we felt this was the best way to care for the community and its needs around cancer care going forward for the future. Speaking to the growth equation, partly what we intend to happen as a result of this partnership is, as you grow, you can provide more subspecialized care. You can have more specialty focus by our medical oncologists in different areas of cancer. And then really that can help to build upon the existing backbone that we have for advanced subspecialty practices for surgery and others to really grow those. And so I just think that's one of those things that we recognize is an opportunity within the partnership. And over the years, our volume of patients has remained relatively constant. And so we hope that this is and intend that this is a catalyst for some of that additional growth as we see the growth occur in the community. As I mentioned, there's a lot of things within the cancer program that we intend to maintain so that it doesn't feel like two organizations, two separate corporations working together. Care conferences is one of them. So this is where the rubber meets the road in terms of figuring out how you're going to care for patients. Those will continue as they have done today. So the care team getting together, looking at the specific clinical information for a patient, how they then proceed with the care plan, all that will continue. As I mentioned, it's still in the same location, embedded within the cancer center as it is today. Part of what we've set up in this arrangement is that there would be shared space where the offices would be next to one another of the providers and physicians. We'll have communal, hopefully after the pandemic, there'll be more communal use of space, but we intend that there's, that's also available for folks. So it's not sort of the separation that you can imagine could happen. Doors are going to remain open, so it's going to feel more seamless in that matter. Just due to the nature of the partnership, billing and financial matters are separately handled, and that's one question I believe we had coming in prior to this session was around that. So it is the nature of the arrangement that each institution will bill separately for the services provided. And so this is something that we're really excited about. We feel that this is a great opportunity that we can see benefiting on so many dimensions across access to care, across the quality opportunities and quality improvement, across getting the name out about the excellent care that Overlake provides in concert with SCCA as it relates to cancer care. So a lot of things that we're really excited. It hasn't been without its challenges in terms of making sure that as you might imagine, a transition like this is very complicated. But so far, everything is on track for our July 1st go-live date, and so there'll be more to come.
Great. Thank you, John. And hello, everybody. I'm Molly Stearns. Welcome, and I want to add my thanks to you for being here with us today, and also for the questions that you pre-submitted, many of which I think you found were answered in the presentations. And I will, I'm going to go through and pose a few to Christy and John that weren't touched on. We've received a few in just over chat or email. Please keep them coming. We'll field as many as we can. So don't be bashful, don't be shy. Let's hear from you. Just to add, John, you did touch from a patient perspective a little bit about what will change in terms of the billing. Talk a little more, both either one of you, about what will it feel like if I'm walking into the center with my diagnosis? What will change in terms of the doctors understanding, will they both see my charts at the same time? How will that all feel to the patient?
Sure, I can add a little bit, and then Christy. So initially, the two organizations will be on the same medical record as they are today. So that on the Epic medical record system. So that'll be helpful, particularly in a transition period here, that the records will be accessible with ease, and it's effectively on the same system as it is today. There will be different, signage, of course, indicating sort of this is the SCCA medical oncology area, and here's the overlay area. But again, it's embedded within the center, and even the way we're kind of representing it externally, which you saw, kind of speaks to there's a cancer center and there's two organizations working together for that in a partnership. I think there's also we have added some of these navigation resources so that, and they will be working together. So SCCA will have navigation resources and also us on the same side to look at how do we navigate that complex journey of cancer care, also in the context of two organizations. So it's our feeling, and we've put a lot of pre-thought into this in terms of trying to ensure it can be as seamless as possible. And so that's our intention.
Yep. Yeah, and I guess I can say so we had to do a little remodeling in the Cancer Center because we do have to create some sort of actually very minimal physical separation between the oncology, medical oncology clinic and the more surgical oncology and radiation oncology clinics. But the remodel part of that is done, and those of you that are familiar with the flow and the openness of things in the Cancer Center, I have to tell you I'm very pleased with how the remodel went. There's a couple extra doorways, and the doors will remain open for easy patient flow, and maybe more importantly to the patients, easy flow of the providers, of the doctors. So we will still essentially all be working in the same clinic, which I think is what really facilitates our team approach to cancer care. When we were first talking about this affiliation with our oncologists, I truthfully said, I think this is going to be fine because we're already used to working as one team, and we intend to continue working as one team. We will still have multidisciplinary tumor boards where the surgeons and the oncologists and the other providers, the social workers, the clinical trials coordinators meet together. So we're going to still have joint provider meetings on a monthly basis. So we're fully intending to continue to function as one team. I think that the addition of our RN clinical navigators is really going to help tremendously in coordinating care. I think you may, those of you that have been in our cancer center before for the care of yourself or a loved one will probably experience that it's better coordinated as a result of this, because we're going to be paying special attention to record sharing, to coordinating care, to making sure that those transitions between surgery and medical oncology and radiation oncology are even more seamless. So I'm looking forward to the future.
That's great. And I should add, as things continue to open up around the hospital, people who want to come and see what the very few modest changes that were put in place, you could work with us at the foundation office and we can see how we can do that in a way that's safe for everybody.
Be happy to give people a tour.
I think that you will be very happy with how it looks. It looks the same. Yeah. This is a question submitted online just recently, Dr. Harrington. How does, I'm going to read the question. Does Overlake Cancer Center have genetic testing and counseling available for example, for children of cancer patients?
Yes, and it's currently in transition. So we formerly had a full-time cancer genetics counselor on site seeing patients 5 days a week. And we loved her, and unfortunately she took a job in industry. So, and this is recently. So cancer genetics counselors are in high demand. Currently, we have genetics counseling available via telehealth And this can, and in cancer genetics counseling, you don't have to have a cancer diagnosis. You're right. You can be a child of a cancer survivor. So yes, we do have services available. And with the SCCA partnership, I know that we will be able to provide on-site, in-person services once the affiliation goes live in July. We expect that the new SCCA genetics counselor will be available weekly, but not daily, at least initially, until we see what the volume is. And also on the Overlake side, we are actively recruiting for cancer genetics counselors. So if you know anybody, have them check the website.
Good. This was submitted earlier. Just the success rate of our breast cancer treatment program here at Overlake.
Yeah.
Christy.
So, so this data comes from the National Cancer Database, or the NCDB. And so for stages 0 through 2 breast cancer, patients treated at Overlake have survival rates that are equivalent to patients treated at other institutions in the database across the country. For stage 3 and 4 patients, we can't really accurately comment on our survival compared to the survival of patients treated in other centers, because we don't really have that many stage 3 and 4 cancer patients. There's this thing about statistical significance. So I think a lot of times patients who are diagnosed with later stage cancer may choose to go to an SCCA or an MD Anderson or a Sloan Kettering for their care because their cancer is very advanced. So I can't really speak to our survival rates in those settings. I suspect that with the SCCA affiliation and with the availability of even more clinical trials, that perhaps we will be seeing more patients at Overlake with advanced stages of cancer.
Probably true. To what degree does the center incorporate integrative medicine?
So that's a great question. So in terms of looking outside the big three, medical oncology, radiation oncology, and surgical oncology, the more integrated approach would be, we are currently on-site providing oncology massage therapy, physical therapy, supportive and palliative care, and nutritional care through our oncology dietitian. Specifically, integrative oncology, like dealing a naturopathic trained oncologist, we are providing that through community affiliates currently, and those community affiliates are those with a good track record and a long-standing relationship with Overlake. We hope to find the right provider to be housed in our cancer center, but that's a dream that is not yet fulfilled.
Okay. Here's a pretty technical one. Christy, this again is aimed at you, that came in earlier. Is Overlake stereotactic body radiation therapy truly a real cyber knife, and how many ports does it have?
Okay, so I had, you know, what is it called? Throw me a lifeline? I had to throw a lifeline, and I reached out to Dr. Nick Serrano, who's one of our radiation oncologists. And so according to Nick, cyber knife, which is also called gamma knife at some institutions, is a form of SBRT, which is stereotactic body radiotherapy. So we don't have the one that's marketed as cyber knife. We have SBRT that's called a TrueBeam at Overlake, and it delivers this type of radiation with similar precision. I mean, that's what you really want when you say cyber knife, is you want precisely targeted radiation, right? And so, so we do have SBRT at Overlake. We don't really use, well, according to Nick, again, we don't really use terms of like how many ports does it have or anything like that, because it's really a treatment portal, and they use a type of treatment that he says delivers almost continuous dose from various beam angles. So I guess you could think of the different angle as a different port. And the specific terminology is called volumetric modulated arc therapy, or VMAT. So,
wow. Okay, I think we've all learned something.
I did.
That's great. Wow. This question came in, and I think I will take it. It was about our educational opportunities for our Overlake nurses. And Mike, you can add on to this if you'd like. In fact, I would, and I'm sure you would confirm that professional development for our nursing staff is a high priority in Overlake's budget every year.
Yep.
And some of that does come through philanthropy. There are designated funds that we receive for nurse education. We actually have 4 endowments that the distributions flow through the endowments specifically for education of our nurses in various areas of the hospital, not all oncology. There is one just for oncology, but there are others as well.
Yeah, no, I would just add, I mean, I think Molly said it well. You know, we think of nurse education and that whole realm as starting with having a very robust residency program to train new nurses in clinical environments, as well as internships that allow them to be in more subspecialized environments, like some of the surgical areas, procedural areas, and ICU, NICU, et cetera. But then also our nursing department in general, in terms of continuous education of nurses as as technology changes, you know, was on full display, frankly, over the last 3 or 4 months when you think about how to respond to something as unprecedented as COVID, and how instrumental our nursing education department was in working with vast numbers of nurses to get them up to speed very quickly in taking care of a patient population that previously they hadn't been taken care of. And then with all the uncertainty around it, also the concerns for their own well-being, and having both their professional talent on display as well as their compassion was just really remarkable. But sort of the nursing leadership that runs our education areas are kind of unsung heroes, because they really do work behind the scenes to keep all of the competencies up.
Great. This one I think is a little bit for both of you, John and Christy. Will the Cancer Center have enough space available for the foreseeable future given the alliance with SCCA? So about growth a little, John, I think, and programmatically, Christy and John, where are we, will we have enough room in that wonderful center?
Christy lives there, so I'm going to let her ask.
Yeah. I guess we'll see. But I think so, at least for the time being. And I think that with creative scheduling and things like that, you can make a lot of things happen. As our surgeons get busier and busier, I think they may be spending less time in clinic, for one thing, right? And we're very committed to using this beautiful space to the utmost of its ability. I think if we get too busy, there may be, or not too busy, you can never really be too busy, but I mean, I think if we get our rooms overwhelmed or our spaces overwhelmed, there's always the opportunity to maybe move some administrative offices in another location or something like that. But I will remind everybody that when we built and dreamed about this beautiful new cancer center, we built it with some room for growth. So I don't think we're in danger of outgrowing our space soon.
Yeah, the only thing I would add is that, you know, we do multi-year campus facility planning, and as we do that, we look across multiple service lines and evaluating the forecast for the disease state, the demographics in the population, market conditions, and then our own ambition. So it's not something that, it's a pretty long planning horizon, really, as we think about making sure that we don't get into that problem. It's frankly a nice problem to have,
right,
if you outgrow your space, but we don't like to put ourselves in a position where it's a big reason why we have a new East Tower that will be opening up in not too many months from now.
I think that brings us to the end of the questions from the group. We're almost to the end of our time. Mike mentioned that new East Tower. I'd like to also invite you to think about, as you're comfortable, we are opening up enough here with proper masking and social distancing and limited numbers, tours of the new East Tower now that it is well on its way towards completion. Estimated completion date is we'll take occupancy in December, and we'll be moving the first of our folks in, and the Childbirth Center will open for business on the 19th of January. At least that's today's date, and things appear to be on schedule. So in the process, as you can imagine, it's looking, it's getting, you won't believe how nice it looks inside, and depending on the floor you're on, it's very finished. The basement has lockers and floors and paint, and the bathrooms are going in on the second and third floors, and there's a lot to see, and we would love to walk you through. So again, please let us know at the foundation if that's something that you're interested in, and we'll arrange to get people in and to see what you helped us be able to build. So thank you, everybody. Christy, John, Mike, all of you, thank you so much. Scott, for moderating. Yes. Thank you so much for joining us and for making, just for contributing to Overlake in so many ways, in the cancer program and in other ways across this wonderful hospital. So thank you very much. Please help us learn how to better serve you in this era of virtual meetings. We will be sending you a questionnaire. We really would love your feedback. Be as honest and creative as you can in your thinking. We need to be able to stay in touch with you and give you the information that you are interested in receiving, even though we can't invite you here for lunch, where we can do it a little more on a one-to-one or a personal small group basis. So please let us know how we can best serve you during this interesting time. And with that, we're adjourned. So thank you.
Thanks, everyone.
Yeah.
Thank you.
Thank you.